Today, we're going to be talking about how chronic lymphocytic leukemia weakens your immune system and what you need to know. Our speaker for this event will be Dr. Andres Chang. Dr. Andres Chang is an instructor in the Department of Hematology and Medical Oncology at Emory University in the School of Medicine. Dr. Chang received his PhD in molecular and cellular biochemistry and earned his medical degree from the University of Kentucky in Lexington, Kentucky. He completed his residency in internal med and a fellowship in hematology and medical oncology at Emory University in medicine in Atlanta, Georgia. As a hematologist, Dr. Chang specializes in treating patients with hematologic malignancies, including leukemias and lymphomas. He is a member of the multidisciplinary care team in Winship's Bone Marrow and Stem Cell Transplant Center, and he is also a member of the Cancer Immunology Research Program at Winship. All right. And with that, I'm going to go ahead and turn it over to you, Dr. Chang. Thank you for joining us today.
Thank you very much for having me. Let me go ahead and share. Okay. All right. Good afternoon, everybody. Thank you very much for joining us this afternoon. As Alton said, my name is Andres Chang. I'm one of the faculty members at Winship Cancer Institute, and today I'm happy to share some information about the immune deficiencies in CLL and how to manage an infection and prevention. And so the objectives of this talk is to understand the basic function of the innate and the adaptive immune system and how these branches of the immune systems are altered in patients with CLL or SLL. And for the purpose of this talk, I would just refer to as CLL. We also want to understand the risk associated with this immune system changes, and then to provide a big overview of the strategies that we have to minimize both the frequency and the severity of infections, and the potential strategies that we are exploring currently to reconstitute the immune system. And so the immune system is divided really in two large branches. The innate immune system, which is shown here on the left, and the adaptive immune system, which is shown on the right. And each of these branches of the immune system are divided and have different tools and different sets of cells, each of them with very distinct function that overall help protect us both from infections and other malignancies. And so for the purposes of this talk, I just wanted to kind of think of the two branches of the immune system as having different roles. The innate immune system works against most pathogens and is really the more primitive immune system that is present even in some invertebrates. It generates an inflammatory response, is very fast onset, and the way it does its job is that it recognizes certain patterns that are present in cells that are not our own. These cells tend to be short-lived, and this type of immune system is already present and functional even at birth. And so unlike the innate immune system, the adaptive immune system generates an antigen-specific response, which means that it responds to one specific thing that it recognizes, and it can virtually recognize anything that it can be presented. This has been very useful both in infection prevention and trying to educate our immune system through vaccinations, for example. But also, it is a very useful tool that we have learned to exploit in medicine in order to develop new therapies. The system as a whole has a slower onset, and so it takes several days to maybe a couple of weeks for us to generate a very good adaptive immune response. And very importantly, though, once we generate that adaptive immune response, our bodies actually remembers whatever it got exposed. And so the cells that are generated are very long-lived, and they can evolve over time so that we can be well protected, and our body knows what to do when our bodies get exposed to antigen that it has been previously exposed to. And so just to compare and contrast of the two different immune systems, I like it to think that the innate immune system is just a pattern where you have maybe a child who loves candies, and then as long as they recognize a candy, they will go there and they will reach out for them. Whereas the adaptive immune system is the type of person who only likes one specific candy, and so they all reach and pick out of the individual purple M&Ms. Now, there are many changes that happen in CLL, both in the innate immune system as well as in the adaptive immune system. In the innate immune system, there are several different changes. For example, lower complement levels, which are a series of proteins that essentially poke holes in the membranes of bacteria and other pathogens, and so allowing or facilitating their killing. Um, some of the cells have impaired immune function, such as the neutrophils, and then there are some cells that sort of help control how big of an immune response we generate, called immunosuppressive monocytes, that are present in higher numbers in patients with CLL. On the adaptive immune system side of things, there are also several changes that occur. On the figure here in the far left, we're seeing that the antibody IgG levels tend to be lower in patients with CLL as they progress through the different stages of CLL. Uh, and this is probably one of the better recognized immune deficiencies, and one of the ones that we can address, as I'll allude to later in the talk. There are also, however, changes in other branches of this adaptive immune system, including changes in both the T cells, the T cell numbers, as you see towards here in the middle, with changes in the different composition of these T cells in the graph in the, that shows the CD4 to CD8 T cell ratio. And then the function of these T cells are also impaired. And on the far right, you're seeing two different immune cells interacting with each other. And oftentimes in CLL, these kinds of interactions are abnormal, leading to suboptimal immune response by many of these cells. Now, CLL in of itself can cause many of these immunological changes, but in addition to the changes that is caused by the disease, many of the treatments that we give in order to treat CLL and its complications can also alter the immune system. As you all know, CLL is a cancer of the immune system. These are B cells that have turned malignant, and therefore many of the treatments that are designed to treat CLL will also affect the immune system, particularly B cells, in some way or another. For example, the anti-CD20 monoclonal antibodies, uh, uh, these are the agents like rituximab and obinutuzumab. These antibodies recognize B cells, good or bad. And so when we use these treatments, we are hoping to deplete the malignant CLL cells, but in the process, the non-malignant B cells are also going to get depleted. We don't use cytotoxic chemotherapy much more anymore in our treatment for CLL, but for people who have been diagnosed now for quite a few years and have been exposed to these chemotherapies, they might also have longer term effects on the immune system. And then some of the newer molecules like the ibrutinib, acalabrutinib, zanubrutinib, venetoclax, all of those will target proteins that are also present in immune cells and therefore can affect how these cells function. And then the newer therapies, such as cellular therapies, CAR T cells, and the likes, they all have a target also that are present both in CLL cells as well as in normal B cells. And so the consequences of an aberrant immune system in patients with CLL is that we often see that our patients have more frequent and more severe infections. And this is regardless of whether our patients are receiving treatment or not. Most of these infections are either bacterial infections or viral infections, but even fungal infections can be observed in our patient population. And more often, those infections will affect the respiratory tract. We also see that there are opportunistic infections. These are infections by caused by agents that normally do not really cause much of disease in non-immunocompromised individuals, but we do see, particularly in patients who have gotten treatment, that these infections can occur in CLL patients. Not only can infections occur, but also we see that an aberrant immune system in patients with CLL can sometimes trigger the immune system to attack uh, its own self. And we see that in about 10 to 25% of the patients. And more commonly, we see this as the self-destruction of other blood cells. And so you might hear your physician talk about autoimmune thrombocytopenia, autoimmune hemolytic anemia, but the destruction of other immune cells are also possible and have been observed in our patient population. Aside from infections and autoimmunity, an aberrant immune system also leads to an increase in other types of cancers. In some studies, they suggest that there's up to 2.2 times the risk of different cancers. And this is because the immune system normally also has a role in surveillance and in trying to keep those cancer lesions controlled. And then from a treatment standpoint, as we move towards more individualized therapies and cellular therapies, we also see that um, uh, immune cells that do not work very well to begin with might lead to treatments that might not work as well as we had hoped for. And so these consequences of an aberrant immune system were painfully patent when during the COVID pandemic, right? And so at the height of COVID pandemic, for example, we see that patients with CLL had very high hospital admission rates and even a mortality rate that ranged anywhere from 15 to 50%, depending on what studies you look for. Um, Not only that, but we also see that in other work that has come out since then, that patients with CLL who have documented some sort of a secondary immunodeficiencies, they do have much higher rates of any infections, but also severe infection compared to those with CLL who don't necessarily have a documented immune deficiency. We also know that vaccine responses are not as good in patients with CLL. This is just a paper that our group published a couple years ago looking at COVID vaccine responses in our patient populations with CLL and with non-Hodgkin's lymphoma. And if you see in this data here, this is from two different papers, we see that patients with CLL and non-Hodgkin's lymphomas really don't have as good of antibody titers after vaccination compared to individuals who do not have non-Hodgkin's lymphoma or CLL. And that if these patients get a booster vaccine, you do see some boosting, but the amount of antibodies that are produced from the booster vaccine is much lower compared to people who, again, don't have a health, don't have a non-Hodgkin's lymphoma or CLL. We know that after vaccination, patients are still at higher risk of experiencing breakthrough infections. And this is just a study showing that among all patients with cancers, really the individuals who have either leukemias or lymphomas will have the lowest vaccine effectiveness at protecting the individuals from breakthrough infections, which by definition means an infection after vaccination. And so to summarize, we know that there are several changes that occur in the human immune system in patients with CLL. We know that that the complement system is impaired. Many of the cells in the innate immune systems are impaired. Cytokines and chemokines, all those are signals that that allow the immune system to communicate, and there are many different changes that I did not cover today for the sake of time that occur in patients with CLL. And then in the adaptive immune from the adaptive immune response side, we also see that there's significant changes both in the function and the numbers of T cells and B cells, and that leads to an impairment in cell-mediated immunity and also in humoral or antibody-mediated immunity. And so, what can we do today to reduce the effects of the effective immune system? What can we do to uh, prevent all those complications that we talked about, right? Well, um, one thing that I do want to stress is that an ounce of prevention is worth a pound of cure, right? And so, in other words, many of these common sense things, common sense measures really do work, and those include avoiding sick contacts, having good hand hygiene, avoiding contaminated food, for example, wearing masks in places where there's a high risk of transmission, improving the air quality, having good public health measures, having good community surveillance, all those measures have really can really cause a significant impact in terms of how many infections are both circulating in the community, but also within one's household. The figure here on the right is just an example of how these common sense measures have been working. So this is data from around the world on the prevalence of influenza or flu over time. And so if you look at 2019, 2020, this is the around the area around the pattern that we would expect, where in the summer we see that the rates of flu infections are typically lower. Remember, this is worldwide, and so what in our summer, flu tends to be more prevalent in the south, and then in our winter, flu is more prevalent in the global north. And so uh, in the winter time in the 2020s, we see that there's a big peak on all different strains of influenza viruses. But then in April of 2020, right at when everything closed and we became all isolated, we started wearing masks and all this, we essentially wiped out influenza from almost around the world. And so, and the infections didn't really come out until about 2022, which is when we started removing many of these uh, measures, and people started losing up and coming out again. Now, this is not to mean that we need to be in a permanent lockdown, or that we need to do this permanently, right? But for people who have a compromised immune system, I think that instituting and being aware of these patterns and being aware of these benefits does become important, because then one can make a decision whether we is worthwhile to attend certain events, or whether to be exposed in certain areas or not, whether you need to be more diligent or less diligent in hand hygiene and wearing masks and so forth. Now, in terms of vaccines, I just mentioned a few minutes ago that we know that patients with CLL have suboptimal antibody responses to vaccines. But I also show this graph here on the right, where even though we know that there's a suboptimal response when patients get boosted vaccines or additional doses, these doses of vaccines might actually help at eliciting higher antibody titers. The other thing that we do not know very well still is what are the effects of these antibodies on T cell responses. And so without any clearance on that, I would generally advise my patients that some response is better than none. And so even though the antibody response is suboptimal, if there is a chance that somebody might benefit some from these vaccinations, I will still recommend it. And so typically, the recommendations for our patients with CLL include their annual influenza COVID vaccines, RSV vaccines, pneumococcal vaccines or pneumonia vaccines, and then shingles and Tdap, and be up to date with those vaccinations that might not occur every year. Additionally, and probably more important, is to encourage vaccination of close contacts. members of the family, members of the same household, roommates and the likes, because these are oftentimes the people who end up sick before and can in turn uh, lead to illness in our patient population. And so by vaccinating them, which in theory vaccines might elicit a better response, then this might protect our patient population as well. And then finally, just as a cautionary tale, we should avoid live vaccines, particularly during periods of significant immune suppression, because these live vaccines, even though they are attenuated viruses, they're still alive, and therefore they can replicate when the immune system is particularly suppressed. Now, you've also heard the term probably of antimicrobial prophylaxis. This term really means to take something to prevent an infection. We had a drug named AZD7442, or Evusheld was the brand that was prophylaxis and given to our patient population to prevent infections. This agent is no longer available because it no longer was effective against some of the new viral strains. But there are new agents that essentially act in a similar manner. One is called pemivibart, and this one is actually it has actually received emergency use authorization, even though the publication for this and the data of it that informed this publication has not been really thoroughly peer reviewed. And then sipavibart is another monoclonal antibody that is in development for this. Now, these might or might not be accessible to everybody, and these are all COVID-19 specific antibodies aims again to really prevent one specific infection. But there are also other agents that we can use to prevent other types of infections or infections in general, one of which is the administration of supplemental immune globulin, or IVIG. There is actually a clinical trial that is ongoing, really testing the efficacy of this treatment approach. Although many of us have already been giving IVIG to patients who have recurrent infections, and this is just below here are just some data from two different papers that were published recently, showing that people who have a recurrent risk of infection, that risk actually decreases once they start receiving IVIG. So this might be a strategy worthwhile to discuss with your provider, with your CLL provider, to see whether this will be of benefit to you or not. And then there are a series of antiviral and antibacterial and antifungal medications that might or might not make sense in your particular case, depending on which kind of therapies and how long have you been on therapies and so forth, and those need to be discussed at an individual level. Now, once if somebody has had an infection, then the key really is to initiate treatment as soon as possible. And so what this means is that our patients should really seek care at the early signs of infection, seek testing, seek care, because there are some infections that we actually have treatment for, right? Like influenza, we have also Tamiflu or Tamiflu. For COVID, we actually have 3 different drugs. For bacterial infections, we have several different antibiotics. And treating early allows those treatments to be not only more effective, but also prevents more serious complications. Now, just a quick note about cancer prevention and management. As I mentioned, part of the consequences of having an impaired immune system is that the risk of secondary cancers or other cancers do go up. And so using some of these known prevention mechanisms really become important. These include the use of sunscreen, avoiding tobacco products or other carcinogens, and really overall having a healthy diet and a healthy lifestyle. I typically encourage our patients to really be proactive at obtaining the age and risk appropriate cancer screening that are recommended. That includes routine skin exams, breast cancer screening, colon cancer screening, lung cancer screening, if applicable. And then if a new cancer is diagnosed, that should be discussed with the cancer doctor very soon so that good treatment can be put in place early on. Now, there are a couple of different things that have been understudied in order to try to um, reverse this immunodeficiency in our patient population, because this will be considered one of the ideal scenarios, right? If we can actually somehow um, reduce or reverse completely the immunodeficiencies that happen in patients with CLL. There are data that have been published suggesting that BTK inhibitors, in particular ibrutinib, might improve the function of T cells. But also we know that BTK inhibitors, because they act on a molecule that is also very important in non-malignant B cells, that these inhibitors also reduce the antibody responses that patients might obtain from vaccination, for example. We don't use these drugs anymore in general for our CLL patients, but there were a class of drugs called PI3 kinase inhibitors that were briefly used, and those might also improve T cell functions. But then the reason why why we stopped using them is because we started observing that these patients also had a higher risk of getting opportunistic infections. And so, in general, I would say that our understanding of how we can reverse this immune deficiency is still very poor. A lot more studies are going to be needed to clarify, one, the mechanisms of the immune deficiency in CLL, and also how to reverse it. And so I really encourage our patients in general to participate in research studies in order for us to be able to advance in this area. And so to conclude, I would like to reiterate that individuals with CLL have a dysfunctional immune system, and that puts our patients at higher risk of infection, of secondary cancers, and also of autoimmune disorders. I want to emphasize that prevention is really better than treating. And so common sense measures work, such as vaccines, pre-exposure prophylaxis, if applicable, and some of the community and public health measures. I encourage people to really avoid exposures to carcinogens. And then early treatment of confirmed infections and cancers is better than waiting. And then more studies are needed really to understand the mechanisms of immune suppression and how to reverse this. And so with that, I'll be happy to take any questions.
All right. Thank you for that, Dr. Chang. That was super informative, and I think I'm I have a lot of questions, and I'm sure others do too. Um, Now is the time for questions. So if you have any questions for Dr. Chang about today's presentation, now's your time to ask it. Please do so by using the Q&A or the chat function. With how many people we have in here, I think it might be a little too much to ask you to unmute. So if you could please just type those questions into the chat, I'll go ahead and read them out. And if you need to hop off prior to the completion of our Q&A, we understand. You will still have access to that post-event survey when you leave. So one of the first questions that I wanted to ask, as a couple are rolling in here, but you mentioned the importance of having getting the people around you vaccinated and how that can really be important. And a term that I've heard kind of thrown around is this idea of herd immunity, where if you kind of help vaccinate or help kind of as a group stay healthy, you can protect those who may not have the immune system to really fight these infections themselves. Is that the same sort of idea here?
Yes, yes, absolutely. So the term herd immunity is applied to more of a general population and society, right? But and we see that sort of in action with how the pandemic kind of unfolded by having more and more people either infected or vaccinated, and then that puts pressure on the virus to really get attenuated, and it also put pressure on the virus for a while, in which we noticed that the infections rates really went down. Now, when I say vaccinated close contacts, it's a little bit more, it's the same principle, but it's kind of closer to one's own bubble. And so if you look at just kind of different circles in which one lives in, this is really the closest circle that we're in. So people we are interacting every day, right? Or maybe every week. Those people really should get vaccinated, especially because we all go out and we have different circles that we interact at any given time. This is especially true with kids because in school, right, they can bring many different things, and so vaccinating kids and so forth really can help both decrease the risk of severe infection in them, but also decrease the risk of them um, carrying the virus and then infecting others.
All right. And then we've got quite a few questions rolling in here, so I'm going to start asking those. Betsy asked, do you recommend a COVID booster for your patients mid-year?
Yeah, so the question about vaccines for COVID, I think you know, we're at an age where there is a lot less that is known. We're basing it off of how the responses are and how to protect people from other vaccines, mostly influenza, for example. And so I think that there's only I wouldn't necessarily we all have to find a happy medium in which we explore this question, and we shouldn't expect patients to be vaccinated every couple months, for example. But then I also don't think that they should not be vaccinated at all. I think that if you get vaccinated once every season, for example, I think that probably is sufficient. This is how the vaccines have been getting updated so far. We don't have any data right now to suggest that vaccinating more often than that is really led to any benefit. And in the case of mid-year, particularly for us, this really will fall right around the summer when more people are outside, and the risk of infection might be lower during that time, and so it might not necessarily be something that needs to be done for our patients.
Great. And I think in that you kind of answered another question that came in from Ivy asking how often should we get revaccinated for each condition? And it sounded like your answer was kind of follow the recommended guidelines there.
Yeah. So as of right now, I think the ones that we get more sort of vaccination that are more often, and that's annually, will be influenza and COVID because of the changes that are associated with the virus. But I think in general, I would just follow the guidelines that are put out by the CDC.
All right. And then this is a really good uh, question for everyone because I feel like everyone can relate to this. Is stress a factor? Does being stressed weaken your immune system even further?
Yeah, that's an excellent question, and I think that is a question that many people ask, and we all kind of sort of feel like when we're very stressed, we get sick, right? And so, um, but I don't think that there is any concrete data, and trying to really tease that out objectively is a bit difficult, kind of from a scientific standpoint. I do feel like, stress do lead to several things downstream, like not sleeping well, not eating well, not exercising, right? And all these things probably add up and might have some effect, but what precisely is the effect? I'm not sure that we can answer that.
A lot of variables at play there. Another great question that I think can uh, apply to a lot of people here is a question about attending a large party, like 40 people, there's food around, so you're not able to mask up the whole time. Are CLL patients generally safe to attend these sorts of events, or should they maybe avoid them?
Well, I think it depends. And so this is one of those scenarios, right, where we have to balance risk versus potential benefits. So if this is a 40 people party where it's just a bunch of strangers and you don't particularly care, and it's just like a I have to be there because I have to, then it might be a good idea to not necessarily go, particularly during time periods where infection rates are high, right? But on the flip side, if this is, you know, your son's graduation, your daughter's wedding, and it happens to be a smaller wedding, I'm not sure that getting, you know, avoiding going to those special events is really uh, good, meaningful quality of life. And so I think that it really depends on what the risk is, and how to and probably take some steps to sort of mitigate those risks, right? Maybe during that ceremony, don't sit right in the middle, sit or, towards the end of the roads and things like that. Um, Again, things that we don't necessarily have a lot of data on, but things that might make sense from a logical standpoint.
All right. And then let me find my place again. All right. Next up, we have also complete a 15-month treatment cycle of Imbruvica and Venclexta. Once completed, what impacts can I expect on my immune system?
Yeah, it's a good question. I think the long-term impact is something that we might not know. Both venetoclax and ibrutinib are drugs that eventually will leave your body, and they don't necessarily cause a complete wipeout of the B cells or the T cells in the body. And so, presumably, the amount of immune suppression and the length of time in which uh, the immune system is suppressed is probably shorter than some of the other treatments that we used to give. Now, the whether what's the sort of end result, I think also depends on how deep of a response a patient receives from any given therapy, not just this one, because again, CLL cells being immune cells can still receive signals and give signals to the rest of the immune system. And so um, I do think that there's going to be some degree of immune suppression. The time frame is probably going to be shorter, and how much immune suppression there will be will partly depend on how deep of a response you'll get from the treatment.
And then next up, we have, based on your graph, it looks like more advanced CLL, the more compromised your immune system is. I'm currently asymptomatic. Can I assume that my immune system might be stronger at this point?
In the grand scheme of things, that might be true. But if you notice in that graph, there is a really wide variation from from one person to another. And so, some people who have advanced disease do end up having uh, preserved high immunoglobulin levels, whereas some people who have early stage disease might have already a compromise um, IgG level. And so, um, in the grand scheme of things, it is true. The more advanced the disease, the more likely patients are immunocompromised. The longer people have the disease, the more likely people are immunocompromised. But it's not an absolute.
Right. And then we have three questions here. So the first one is COVID-19 still as bad for CLL patients?
No, not as bad, fortunately. Yeah. So as the virus have evolved, and as we've acquired herd immunity, and as even our patients have gotten some sort of immunity to it, both the mortality and the hospitalization rates in our patients have dropped significantly, but it still remains higher than the general population.
Right. And then next up is, have you heard of Innovid? And if so, what do you think about it?
Uh, Innovator Premgarda.
They specified Innovid, Enovid.
I am not sure. I would need to know which one is that one in generic name.
Right. And then third, and this one's a little specific, but I think it can relate to just environmental factors in general. I've worked for about 30 years in fairly close proximity to a copy machine. What are your thoughts about copy machines and carcinogens? So kind of tackling that environmental factors.
I'm not sure that I've heard much about copying machines being carcinogens. I think in general, the carcinogens that we think about are, certain pesticides and even low doses in certain food products, for example, nitrogenated compounds and things like that. Um, are the things that I will be a little bit more concerned, right? Tobacco products being the most obvious one, asbestos being another one. Alcohol, high levels of alcohol is a carcinogen because it can lead to liver cancer, and so those are more the ones that I'm talking about than copying machines or cell phones and the like.
And they just want a quick follow-up here. Innovid is a nasal spray of oxide classified as a medical device. I believe it was used by some leaders of CLL organizations.
Okay, so yeah, I know which one it is. I'm not sure that it ever really picked up that much, and so I don't typically prescribe that to my patients, and I think it was probably um, used more in the people in Israel and in Europe, but I typically don't prescribe that to my patients.
And then this question actually comes from an individual who is unable to attend the live session today, but I told them that I would ask their question for them. So I was very recently diagnosed with CLL, and I'm on the wait till treatment is needed plan. Why is that doing treatment early, and then in parentheses, before red blood cells and platelets are impacted, isn't indicated? Wouldn't it make sense that providing treatment to lower white blood cells would slow progression and reduce number of lymphocytes?
Um, it kind of makes sense, but the data hasn't really panned out, right? And so one thing that we know, and this has been studied both with traditional chemotherapy as well as with some of these novel agents, is that there's really no overall benefit in starting treatment early. And I think that the rationale that I give my patients is that we we know that our treatments work equally well if we start them right away or if we start them when we absolutely need it. We also know that, at least as of right now, none of these treatments are considered curative. And for the most part, people who are in the watch and wait period, they are asymptomatic. In other words, they're feeling well, right? And so if somebody's feeling well and I cannot cure the disease, and I know that the treatment is going to work well regardless of when I started, then the only thing that I can do at that particular point, if I give the medicine, is to give that person a potential side effect, right? And
Mhm.
so, because of that, I think unless we have good data showing that this really leads to a meaningful improvement in the overall health of our patients, I don't think that instituting early treatment is going to be something that we will do.
And then I have two questions in currently that are asking about supplements. Are there any supplements that are recommended that might be able to help boost someone's immune system?
I think that as long as somebody has a healthy diet, and I don't think that any additional supplements are going to be needed and are going to provide any meaningful benefit in terms of boosting the immune system.
And then tied on to that one, is drinking alcohol in moderation, say 2 glasses of beer a week, is that going to be super detrimental to these individuals, or is moderation okay?
I think moderation is fine. 2 glasses of a week or something like that. I don't think that it has that in the long run is going to have a significant impact. I think that the impact is if people start moving the line of moderation, right? And so people will be like, well, 2 glasses, well, maybe what about four? What about six? What about eight? And then if you start going up, at some point, it's going to start causing damage.
All right. And then This one says, I've been neutropenic for about 6 months with monthly lab draws. My IgG is currently 464. I've had congestion, but no major infections. Should this individual be concerned? So some minor symptoms, but is that something that should really raise a big red flag for them?
Um, Not necessarily major red flags. I think that one of the common sort of misunderstandings about reading CBC counts is that as people's white blood cell count or lymphocyte count goes up, the percent neutrophil is going to go down. And so I discourage my patients from looking at the percent neutrophils, but rather the absolute neutrophil count. And oftentimes, even if the percent is low, the absolute neutrophil count is fine, and then these patients are not neutropenic. Um, some individuals might be neutropenic just by uh, virtue of their background, and some people, particularly those with African ancestry, they might have a benign condition where their neutrophil counts tend to be a little bit low to begin with, and so when they get CLL, it might go down a little bit as well. It, as long as there are no significant infections or infections that are so frequent that it's affecting quality of life, I don't think that this is something that needs that will be particularly concerning.
And then I'm going to try to avoid some of the more specific questions that might be about individuals, individual situations, just to try to keep this a little bit more broad. Um, but let's see. Uh, Trying to think of some good ways to reword some of these. Let's see. Um, so if an individual is treated with obinutuzumab and venetoclax, which is a pretty standard treatment at the moment, um, how much is their immune system do you expect to be impacted by that? And then what are some maybe treatment options for them to look forward to down the line?
So one of the main impacts will be the B cell depletion that is associated with the obinutuzumab. We know that for obinutuzumab, the period of in which we do not detect B cells in circulation tends to be longer than in patients who receive rituximab, and so that period might be long, might be even over a year in some patients, and so that will be something that will probably be expected. Um, the venetoclax, again, with it being sort of a pill that has a shorter uh, life inside somebody's body, it should lead to somewhat of a relatively quick washout period, and so the immune system should not have much of a long-term effect. At least that will be the hope. Now, after obinutuzumab and venetoclax, if you need other treatment regimens, I think that really requires a personal conversation with the physician, or if that physician, for example, doesn't necessarily have much of a good idea, I think that getting a second consultation or a second opinion might be worthwhile, because it really depends on what that particular in that particular case. Some people are getting venetoclax and obinutuzumab as frontline treatment regimen, in which case we do have other options that are sort of FDA approved standard care. But some people are using this treatment regimen after progressing through a couple different lines of therapies, and the treatment options for these individuals might be very different.
Then we are getting a little shorter on time. But this question that just came in, I think is a good one to talk about the immune system and just how overall health can really impact that. Is exercise, weight training, and cardio overall helpful for maintaining a healthier immune system?
Yeah, and not only that, I think that in general, if we look at there are some early data looking at changes in the immune system composition after exercise, for example, and it seems that there's some benefit, but those data are still somewhat in its infancy. The more robust data I think that we should sort of more hang our hat around is that there are more conclusive data showing that patients with cancer in general, right, patients who have a healthy lifestyle, so exercise, healthy diet, and so forth, they tend to do better, live longer than patients who don't. And so I think that with that in mind, and with this being a cancer, even though it's somewhat of an indolent cancer, I still recommend our patients to really try to keep up with physical activity.
Right. And then if I didn't get to your question, I apologize. We're just getting a little bit short on time. And again, I wanted to keep the questions a little bit more focused towards the immune system and a little bit more broad so that we can all benefit from hearing them. But feel free to email me with those questions, and I will be happy to give you the best response that I can. Um, but that's going to conclude our Q&A session for the day. So thank you, Dr. Chang. That was really helpful. And
Happy to.
then, and then before we go, I wanted to give a reminder about our new CLL SLL therapy guide. This is a new, really cool resource that we've worked on here at HealthTree. So this is a multimedia therapy guide that you can go through and kind of, you'll have your questions. It has links to videos and pretty easy, clear text to really try to make this as approachable as possible because we know that it can be really confusing. This is medically reviewed. We did our best to make it as patient friendly as possible, and it is very comprehensive. So, if you have some questions about potential therapies for your CLL, I highly encourage you to check it out. I think it's a really good resource. And then I wanted to highlight a couple of upcoming events that we have. So on February 19th, we're going to be speaking with Dr. Alvaro Alencar about what chronic lymphocytic leukemia patients should know in 2025. So this is kind of highlighting some of the new developments and should be a really good event. And then on February 28th, we're going to be having an emotional wellness for chronic lymphocytic leukemia patients. This one's going to be with Dr. Lauren Harris. She's a psychologist who specializes in working with oncology patients. So it's really going to try to tackle some of those difficult questions that CLL patients have. So if you'd be interested, I highly recommend that you register for these events. We would love to see you there. And then I wanted to give out one more special thank you to AbbVie, our sponsor for today's event. They allow us to host events like this. So again, we couldn't do it without them. And finally, I wanted to say a thank you for helping us build our CLL community here at HealthTree. I've added my email to this slide. Please don't hesitate to reach out to me if you have any questions about HealthTree or any of our programs. Um, Again, thank you, Dr. Chang, for joining us today. This was a fantastic event, and I really appreciate your time. Um, I appreciate every one of you, and I hope that you have a great rest of your day. I hope to see you at another webinar soon.
Thank you for having me. Have a good day.
Thank you.